Time is running out. In 2017, about 36.9 million people were living with HIV globally, with about 25.7 million people in sub-Saharan Africa alone, representing about 70% of all people living with HIV/AIDS. Nigeria has one of the highest number of people living with HIV. In Nigeria, over 3 million people are living with HIV, with about 24 people infected every hour. HIV presents clear and present danger to Nigeria's future. 94% of people living with HIV in Nigeria are 15 years and above, most of them in the most productive stages of their lives. Because the majority of those affected by HIV are in their most productive stages of their lives, HIV robs countries and businesses of vital labor and also entrenches poverty. Even businesses are not safe from the scourge of HIV. HIV robs businesses of vital manpower and reduces productivity. Expenses on drugs also mean that families do not have enough money to spend on products, goods, and services. So how can we fight one of the greatest health endemics mankind has ever faced? Knowing your status is the first step to take to join the fight to end HIV. Knowing your status empowers you to get help if you are HIV positive and to take steps to prevent spreading it to others. Knowing your status empowers you to get help if you are HIV positive and also to invest in research for a cure. Join hands to end HIV. This message is brought to you by the Nigerian Business Coalition Against AIDS. Time is
Good morning, everybody. Thank you all for joining us this morning. I hope you can all hear me.
Yes, we can.
Okay, I only got one response. I hope everybody can hear me.
Yes, we can hear you.
Yes, we can.
Great. Good. Good morning. This is a very peculiar situation. Ideally, we should all be in one room, which should have been more fun because I'd be able to see your faces, look into your eyes, and tell you thank you so much for being here. But here we are online because of the situation in the country and because of the situation in the world, the COVID-19 pandemic that has put us, in this situation. But thankfully, technology has helped us out, and we're here, and we can still see everybody. We can join from all parts of the world, from wherever we are. So good morning, and again, thank you for joining us on this World AIDS Day. The program organized by HACI International Pandemic, which is gender-based violence and HIV/AIDS. Two main issues that have not really been addressed throughout this pandemic, even though some institutions and organizations have tried we fail to understand that, with the pandemic looming over us, there are still other issues. I know that there were so many health challenges during the lockdown, and a lot of people couldn't get, the necessary aid and support that they needed. So since the outbreak of the pandemic, we've seen data emerging from the front lines. It shows that all types of violence against women and girls, particularly domestic violence, has intensified. I was hearing over the radio yesterday that there's been a 149% increase in the number of reported cases in Nigeria of domestic violence and gender-based violence, especially against women. And I do remember that during the pandemic, the Lagos State government did draw attention to this and calling for women to reach out to the ministry in the Lagos State government that deals with women's issues and, areas where they can report domestic violence and so on. Now, unfortunately, we're starting late this morning, but that is okay. Thankfully, we're all here eventually. That's the most important thing. So let's move on fast as quickly as we can. I'm going to be introducing Rhoda Robinson for her remark. Rhoda is the co-founder of HACI Initiative. She serves as the Executive Director for Gender and Development Programs. She's also responsible for developing and implementing programs of the organization that empower women and girls and advocates for the inclusion of women and young people in development policies and action. Rhoda is coordinator for the Hands Up for Her initiative, a program that promotes the health, empowerment, and rights of the girl child in Africa. She joins us for the opening remarks. I must mention also Rhoda is an IVLP alumna. That's the International Visitors Leadership Program of the US Consulate in Lagos. Rhoda, you have, I would have said the floor, but you have the internet.
Thank you very much, Amarachi. So good to be here. Good morning, everyone. Thank you so much for being a part of this important webinar to commemorate the 2020 World AIDS Day. Your presence here today shows how committed this generation is to ensuring that we put an end to the spread of HIV in our world. The World AIDS Day serves to remind us of the impacts HIV has on our world, denying our fellow humans of the future that they deserve. But more important is the power of our collaborative efforts to achieve an HIV-free world by increasing awareness of the impact of HIV/AIDS and ending stigma and discrimination and improving the quality of life of people living with HIV. As HACI Health Initiative, we are committed to this shared goal and have over the years provided free HIV testing and counseling to over 10,000 young people in Nigeria, and also provided referral services to various populations. We also understand the role that gender-based violence plays in increasing the spread of HIV in our society. And as such, we have implemented and still implementing programs to combat gender-based violence. We are currently running the End Rape Culture Act exhibition, which is supported by the United States Mission in Nigeria, which aims to use visual storytelling to educate the Nigerian population on rape culture, its effects, and how it is perpetrated in our society today, as well as promoting consent culture. Gender-based violence is a complex part of HIV/AIDS equation, and it has been reported that young women are disproportionately vulnerable to the infection. Elderly women and young women are also disproportionately affected by the burden of caregiving in the wake of this epidemic. Female sex workers, transgender women, and women who inject drugs are even at a greater risk of contracting HIV and suffering from HIV-related morbidity and mortality. This is due to the marginalized society and the associated barriers that they face in accessing HIV services. Gender-based violence is a common experience for women, and most of women suffer this form of violence, especially when it comes to intimate partner violence. And this has been attributed to be one of the risk factors of HIV transmission. The stigma and discrimination linked with HIV as a high level of gender-based violence are slowly as
Uh-oh.
eliminate HIV/AIDS as a public church by 2030. It is with this background in mind that Hazy Health Initiative brings together experts across diverse sectors to discuss on accelerating the impact of gender-based violence and HIV programs in Nigeria. We hope these discussions will enhance your understanding and work in HIV and gender-based violence management and will promote a more inclusive and robust response from all stakeholders. Thank you very much and enjoy the rest of the program.
Thank you very much, Rhoda. Just a few housekeeping rules for everyone to understand. You'll notice the Q&A button on your screens. That is available if you have questions to ask any of our speakers this morning. You must remain muted at all times unless you are speaking. And then the recording of the session is being made and will be made available at the beginning. I noticed that we have been recording. So if you do have any need to go over what has been said today, or you want to refer to something in any of the addresses made by the speakers, you surely can. I'm aware that we're supposed to have representatives from the US Center for Disease Control, and I'm not sure that they are available. Rhoda, can you confirm if they have joined? Because I did see it.
We're here.
Oh, great.
We're here.
Perfect.
So,
right here. Yeah.
Exactly. I'm so happy to have you both join us on the program today. Sorry. We have Halilu Usman, who's the communications director for the Center for Disease Control, communications specialist, beg your pardon, for the US Centers for Disease Control in Nigeria. He'll be introducing Dr. Jerry Gwamna, who's the current prevention branch chief for the CDC's Division of Global HIV and TB in Nigeria. They'll both be speaking on integrating gender and GBV into HIV programming lessons from PrEPFAR. Gentlemen, you have the floor. Mr. Halilu first.
Okay, thank you very much. And firstly is to appreciate the invitation and the opportunity to speak at this very important event for the benefit of our colleagues, our friends, and other participants. CDC takes the World AIDS Day very seriously because it's a day that we join the rest of the world to actually remember those who passed on from this deadly disease, as well as to celebrate our survivors, people who are here, who are, witnesses and evidence of the advances that we have made both in science and behavioral change, as well as to recognize and appreciate, all those people who have worked one way or the other to ensure that the people who unfortunately, have come down with HIV/AIDS are given the proper support that they actually needed, both in terms of their physical health and psychosocial support that is needed for them to live, a long, normal life. Having said that, it is also important, and I will be introducing Dr. Jerry in a bit. I just felt it's important we all remind ourselves that HIV actually remains, a leading cause of death and health threat to millions worldwide, even as we speak. We are talking about 1.7 million people who were newly infected in 2019 alone, while, another 690,000 have died of AIDS-related illness, underscoring the fact that HIV/AIDS remains a global scourge, where today we are having more than 38 million people who are living with the disease. But it is not all bad news as far as HIV/AIDS is concerned, because in reality, we have moved from crisis towards control right now. If you all recall, in the early 80s, mid 80s, late 80s, up until early 90s, in all honesty, HIV/AIDS was almost a death sentence. But that is not the case right now, because we have made some significant advances, through science, and like I said earlier, through behavior change that we are witnessing. But the threat remains, and what we are doing right now, especially in Nigeria, is to be able to work with our partners, with people in the communities, individuals, groups, to ensure that we continue to raise awareness so that people would be able to come out, test for this virus, which is actually the very first step in ensuring that we are able to provide the necessary health care measures that ensures these people live a long, normal, productive life. Having given this a little bit of background, I think it is right for me now to invite Dr. Jerry. Dr. Jerry, as earlier introduced, is of course a family physician. He's a public health expert. He has over 2 decades of experience in the management of patients and health programs, including HIV prevention, care, and treatment services. At the moment, he is our branch chief for prevention, the CDC's Division of Global HIV and TB, the Nigeria Country Office. Dr. Jerry has actually supported both PEPFAR and the government of Nigeria in the development and coordination of HIV/AIDS prevention, care, and treatment programs, including establishment of program policies, guidelines, procedures, and strategies over the past 12 years. He will be talking about our intervention, as well as set the tone for conversation around integrating GBV and HIV/AIDS programming in Nigeria. Thank you, Dr. Jerry, for accepting to step in. The internet is yours right now. Please go on. Thank you for the opportunity.
Yeah, thank you very much, Halilu. Thanks, everyone, for having me. This is a very important occasion for me, because these are both dear topics to my heart in terms of HIV prevention, and as well as prevention and also reduction in terms of gender-based violence across the country and across the globe. I'm actually going to talk a bit about our experience as PEPFAR and what we do to make sure we integrate gender-based services into our HIV services across board, for all the sites that we support, and also for the partnerships we've formed with government of Nigeria at several levels, including federal, state, and local government levels, as well as multilaterals we've collaborated with, then including, of course, our key implementing partners across board. We strive to make sure that as we strive to control HIV/AIDS, we also do not leave out issues to do with gender and gender-based violence, because you cannot get to epidemic control without handling gender-based violence and actually reducing that scourge, because there's a big interplay between HIV and gender-based violence. So by way of definition, gender-based violence is defined as any form of violence that is directed at individual based on his or her biological sex, gender identity, or his or her perceived adherence to socially defined expectations of what it means to be a man or a woman, or boy or girl. So it includes physical, sexual, psychological abuse, threats, coercion, arbitrary deprivation of liberty, and economic deprivation of whether they are occurring in public or private life. Now, we know very well that HIV and violence intersect. In most instances, violence contributes heavily to HIV acquisition and transmission, because it limits the ability to negotiate safer sexual practices. It interferes with the ability to disclose HIV status. It also interferes with the ability to access healthcare services across board. On the other hand, HIV actually also contributes to violence in some ways because it increases vulnerability to violence for those who are infected by HIV. It also, creates an opportunity for such persons to be accused of infidelity by partner and family, because in our culture and our settings, generally people believe you have to be promiscuous to get HIV. It also increases the exposure to physical, sexual, and emotional, as well as economic abuse. Generally, again, deprivation, because once you're infected with HIV, and those around you who are closest to you get to know, they kind of keep a distance from you, and they also avoid certain things that would have been beneficial to you. Some would go as far as avoiding buying things from you. So there's a lot of that. And also there's the issue of of course, sexual and emotional trauma, which mostly people infected with HIV suffer from, those that are closest to them in terms of intimate partner violence. When we look at the cascade of clinical care, gender and gender-based violence actually interact with the clinical cascade in a way that can be negative. For instance, in terms of the prevention of HIV, we mainly have pre-exposure prophylaxis and also provision of condoms and other things like that. But then violence can be a barrier for people to adhere to pre-exposure prophylaxis. They can't even go to access, because then the intimate partner or their partner may begin to think that they are promiscuous. So they may have to be careful about that. So that can be one barrier. On the other hand, also those who have already experienced kind of gender-based violence, maybe sexual abuse and all of that, and then they need to be initiated on post-exposure prophylaxis, for instance, to prevent them from contracting HIV. There are lots of things that can prevent them from accessing those services, or even adhering to the treatment if they're given this preventive treatment of post-exposure prophylaxis. They include psychological and emotional stress and rape, stigma as a result of the assault. So they may delay in accessing PEP after an assault due to the fear of reprisal attacks and other things. When it comes to testing, we're looking at the UNAIDS goal of achieving 90-95, which we in PEPFAR actually adopted to 95-95-95. In other words, making sure those who are infected, 95% of them actually access HIV testing to know their status. Of those who access and know their status, we expect that at least 95% of them be initiated on treatment, and at least 95% of those on treatment be retained and sustained on treatment to achieve viral load suppression. And that way, we look forward to achieving an AIDS-free generation by 2030. This is a big deal for us in PEPFAR. That's why we moved it from 90-90-90 to 95-95-95, because we are thinking that the more we do this, the better for all of us as a country, as well as the global community, that we can actually achieve that AIDS-free generation a lot earlier if possible. So within that cascade, again, you find that accessing testing services can really be inhibited, particularly for those people who may be already infected with HIV because of fear of violence from their intimate partners, and also they may even be struggling with disclosing status, so not to mention to access services. So this is a big deal for us here. That's why dealing with gender-based violence and all is very critical. Again, harmful gender norms often inhibits men's health-seeking behavior. So when it comes to initiating ART, they may not come in to initiate ART. Violence is associated with reduced linkage of HIV, care, linkage to HIV care and services, and even delaying initiation on ART. So particularly this is more in women. Again, thinking about how do I disclose if I get the ART, wouldn't my spouse know? And then what kind of treatment will follow? Again, it goes without saying that the same way it has, or you can inhibit gender-based violence, can inhibit accessing care and treatment services. It can also stop somebody from adhering to treatment regularly. Again, fear of somebody seeing the bottle. So we think about it in terms of making sure we prevent violence within our program. So we use the violence prevention framework and response, where we make sure that our HIV services are linked with these other services that are available within communities, finding those who need services and routine clinical inquiry within the facilities. We also make sure we mobilize communities to prevent violence by actually addressing some gender norms that foster violence and all of that, gender-based violence. So we make sure we do those kind of interventions by engaging those communities. Again, providing post-violence care services, the minimum package that we have for those who have already experienced violence, that's survivors of gender-based violence. So we realize that our service delivery points, which are mostly healthcare facilities, but sometimes we also have community spots where the uh, OSSs that we have for key population, one-stop shops we call them for key populations, they actually are natural point for identifying survivors of violence. So we do our best to interact with our healthcare providers uh, to train them on how to interact with people, men, women, key population, adolescent girls and young women who are experiencing violence and have unmet needs for services. So the survivors are able to overcome fear or shame if of disclosure with a trusted healthcare provider. So we actually try to foster that sensitivity, gender sensitivity, and also the clinical acumen of our providers, so that they are able to seek out those who are have experienced gender-based violence, the survivors themselves. Healthcare interactions are an opportunity for appropriate, an opportunity for intervention if appropriate approach is taken by these healthcare providers. So we realize that, and our trainings ensure that they have all of that. We do track wherever we are providing these services, the number of people who receive post-gender based violence clinical care based on the minimum package that we've developed. And these are at least we have them that we can provide the details of all of those minimum package of services that we provide. But where we cannot provide the services within our facilities, we link them up with other sources within the community, particularly when we're talking of psychosocial support and other things, and legal support, police support, and other support that they may need for protection, and all of that will be actually something that we make sure the community-based organizations and other agencies that we collaborate with are linked to these survivors, so they can provide them those care. So we actually provide our services for HIV always on the principles of do no harm and patient-centered care. So this is very critical for us. The packages of services that we provide for post-violence care include counseling for those people who are the survivors, and basically making sure our providers are providing empathetic listening, inquiring about needs and also concerns, then validating and ensuring safety of those survivors. Of course, we treat injuries as well. We provide STI screening and treatment. We do rapid HIV testing and counseling services for them, and referral into care and treatment where we are not providing at the same site. If it is provided at the same site, of course, they access those if they are positive. Again, for HIV, that is, we also provide, again, as I said earlier, post-exposure prophylaxis, emergency contraception within 120 hours, and also referral and linkage to other services like I mentioned earlier, child protection, legal counseling, police, psychosocial support, and shelter, all that is needed. We make sure they have that. So what are some of the clinical and routine inquiry for violence that we ensure our healthcare providers provide? Those are very critical. The clinical inquiry usually is based on the provider's suspicion. He thinks or she thinks this client before them may have experienced gender-based violence. So they are actually asking questions based on what their intuition is giving them as clinicians. Whereas routine actually is what we encourage. We want them to routinely ask. So when a clinician asks all clients who present for specific services about whether they've experienced violence. So these are very critical. So this is what we push forward with for most of our service providers, to be trained to actually provide this, and this will ensure it happens in our facilities. Now, for violence prevention, I had mentioned earlier that we actually mobilize communities to do that. This, most of the time, we make sure those partners that provide OVC and other services do that. Mainly our community-based and faith-based organizations that we partner with. They implement these community mobilization activities that address harmful gender norms that perpetuate gender-based violence. These activities usually target parents, caregivers, community leaders, gatekeepers, faith and traditional leaders, and also male partners of adolescent girls and young women and other community influencers. These are all usually followed by, interactions that will actually bring about normative changes that will see a reduction in gender-based violence. So that also increases awareness about the existence of violence and available GBV response services that we have. So we always insist on having this happening in our programs. So in a nutshell, we are integrating and we've integrated gender-based services across our HIV response in PEPFAR. And I know the national program is also doing the same thing in the national HIV response to make sure that all survivors are provided services, and those who are at risk, actually we prevent them experiencing gender-based violence because of the fact that we know they cause a lot of harm in terms of the HIV response itself, and also the intersection of the two is only fueling the challenges we are facing as a country, and we will not get to the epidemic control we desire without addressing gender-based violence. To foster that, we actually developed gender-based violence quality assurance tool that we use to make sure the services that our providers do provide at the facility level or community level adhere to those qualities, and we assess regularly to make sure these are in order. And the tools actually are very user-friendly, and it makes it easy for us to assess and actually put remediation measures or actions to make sure that we sustain the quality of our services to achieve the goals we've set forth. So in conclusion, our healthcare workers and the community play critical role in preventing gender-based violence, identifying survivors of gender-based violence, and responding to gender-based violence. So when considering the quality of clinical gender-based violence response services, we always remember that community-based gender-based prevention, case identification, and response services need to be just as strong in order to effectively address that gender-based violence component. So it's critical. That is what we do within our program as PEPFAR. I will stop here. If there are questions, I'll be ready to talk about them a little bit with anyone who has them. Thank you so much for the opportunity to speak. Sorry, was I muted all the time?
Nope, we had you all through, with the exception of a few points where the connection dragged a little bit. Otherwise, we had you loud and clear. Thank you very much, Dr. Jerry, for agreeing to do this. And I think we've learned a lot, we've had a lot. I will now turn it back to the organizers and the coordinators, Rhoda and others who are coordinating. Madam is back now with us. Back to you.
Yes.
Thank you very much.
Yes, I am back with you. Dr. Jerry Gwama, thank you so much for reeling out, the intervention programs and all the efforts that the CDC has been doing in Nigeria. I think the main challenge is getting people to believe that there is, believe in the existence of gender-based violence, because many communities still believe that, if there's violence, somebody is the cause of it. It's because of somebody's attitude. It's because somebody wasn't submissive and things like that, So awareness is key at the end of the day. We're going to move ahead on now. Thank you so much again, Dr. Jerry Gwama, for speaking to us. We appreciate, the issues you have raised, as well as the interventions that have been made so far. Good to know that the interventions in all HIV/AIDS services concerning gender-based violence, which is very important. Some of the issues you're raising here, not very popular, to know that help is readily available for victims of gender-based violence. I'm going to move on now to...
Thank you for having me here.
Thank you so much. Toun Okiwale Sunaya is a media entrepreneur and a broadcaster, fellow broadcaster I should add, who established the first women-centric radio station in West Africa. It's known as WFM, Women FM 91.7. If you're here in Lagos, you should know it. It's better known as the Voice of Women. I listen to it sometimes when I do have the time, especially when I'm driving. It turns out that, the station is going to be 4 years old this month on the 18th, if I'm right. Toun, am I correct?
You haven't done badly. We're going to be 5 years old. We're 5 years old.
Oh, 5, sorry. 2016. It was 2016 you were established, right?
15,
congratulations
15, yes.
Congratulations are in order because this is a celebratory month for you. And so glad to have you today. The station has engaged and partnered with various agencies and organizations, as well as individuals, to address issues of gender inequality, financial inclusion and support, child marriage, education, widowhood, and others. I've listened to some of the issues that have been discussed on WFM. You have very great presenters, I must add. They do a good job, of dissecting the issues. And I know that you will become more popular, even if people are not aware. But I do remember meeting you at a US consulate event in Lagos. That's where we met, I remember. And since then, I have been following, WFM just to keep up with what's been going on. Thank you so much. You have the internet as is the language today.
Thank you very much for this opportunity to be part of this needed conversation. Thank you, my sister. And you do a fantastic job as well. Thank you. Casey, we acknowledge and commend your work in protecting the most vulnerable women and girls. Thank you. Thank you very much for all that you do. So, I'll be speaking about the role of the media in addressing GBV and HIV. Today marks 6 years, 231 days since the Chibok girls were captured. Today also marks 2 years and 287 days since the abduction of Leah Sharibu, the Dapchi girl. A year ago and 13 days today, Salome Abu was burnt alive in her Kogi home in political violence for holding a public office. These cases are just tiny fractions of the violence and abuse on women and girls in Nigeria. In my opinion, and in the opinion of Women Radio, the Nigerian media has failed in keeping these cases and others on the front burners for us to end GBV. The role of the Nigerian media is to keep reminding the government and leaders about its duty and obligations. But every day we read about banditry, kidnapping, rape of women, especially in northern Nigeria. And for me, the media has to wake up from its slumber and make GBV a priority. The media must continue to churn out information and statistics, not just to inform and educate, but to influence and trigger public opinion, from blaming the survivor to shaming the perpetrator. So we need to focus on the perpetrator at all times. We need to inform the public where the perpetrator lives, where the perpetrator works, where the perpetrator socializes. And what we're saying is that the media must make living difficult for the perpetrator and deter potential perpetrators. That is one of the ways for us to end gender-based violence, and also, to stigmatization on HIV survivors. When we say the media should play a fundamental role to curb gender-based violence and HIV, we do not mean to merely report when these things happen. It has to continually talk. We have to continually report about it. We must have a regular woman agenda on our editorials. We must give prime time reportage on GBV, on our radio programs, on TV programs, and feature these issues prominently on newspapers' front pages. And so for me, when the media reports frequently, repeatedly on GBV or even HIV, we shift attention to very crucial matters, because gender-based violence is a social, a national and crucial matter. It is not a family or private matter. We have an obligation to the public and the nation. I have said Nigeria did not and do not experience COVID-19 pandemic. The stats are there to back me up. Yes, there is COVID-19 in Nigeria. Yes, we experienced it, but it's not a pandemic for us in Nigeria. Our pandemic is an epidemic is number 1, corruption. Number 2, corruption. Number 3, corruption. And sadly, one of the major consequences and effect of our corruption pandemic is gender-based violence and the rise. So the media must address gender-based violence, HIV in a comprehensive, well-researched manner, and not taken out of context and give 3 minutes airtime or a tiny, insignificant print space. Now, if the Constitution of the Federal Republic of Nigeria identifies the role of the media, that it shall at all times be free to uphold the fundamental objectives, uphold the responsibility and accountability of the government to the people, then that is a simple call for us, a simple call for duty. In my opinion, the media has been compromised, in some cases corrupt. Now, the independence of the Nigerian media is very key in our accountability to end GBV and end stigmatization of HIV. Now, in the case, I'll cite an example. In the case of Akpabio and Joy Nunwe, Godswill Akpabio is Nigeria's Minister of Niger Delta Affairs. And while he was responding on national TV to allegations of corruption leveled against him by John Nunwe, John Nunwe, he was a former acting managing director of Interim Management Committee of the Niger Delta Development Commission. Akpabio reacted to the reporter by asking the reporter to go back and interview Nunwe's 4 husbands, because according to him, according to Akpabio, Nunwe's having 4 husbands is a character issue. So whatever she's saying about the allegation does not hold water. That is violence against Joy Nunwe by Akpabio. And the Nigerian media did not condemn Akpabio. Nigerian media did not report on that verbal abuse. Most media picked up on the fraud allegation, but none except Arise News and Women Radio, who focused on the abuse immediately after the news broke out. I recall making contact with colleagues in the media for need to collectively condemn Akpabio's statement. I didn't contact you, by the way, but I contacted a few media. I was told they cannot report it because of ownership interest. I mean, we reached out to Akpabio, but he declined to talk. And this is a sad reality of most media today. The media cannot afford to be selective in what it broadcasts or prints. We must make the woman agenda an editorial agenda. That is the only way for us to amplify media accountability towards ending GBV and stigmatization of HIV survivors. The media must regularly feature and report on the need to abolish harmful practices on women. I mean, shortly after the lockdown, a friend of mine was in 2 weeks isolation and in a room with the corpse of her late husband. She was made to drink water used to bathe his corpse, and she had her long hair shaved off in accordance to the tradition in Edo State. The trauma she went through and her daughter is unimaginable. These are harmful practices that the media should report on, especially the adverse effect on women and children and the economy. Because during that 2-week period that she was in isolation with the dead body, she couldn't run her business. So the media should consistently report and educate on sexual and reproductive health rights. For instance, how many media today report on the consequences and effects of economic corruption and abuse on Nigerian women? 30 Nigerian states and governors, right, could not account for the looted COVID-19 palliatives in their constituencies. What did the media do to challenge the governors of those 30 states to give account of why the palliatives were kept and not distributed? The keeping or hoarding of those palliatives, not using the palliatives for intended intervention is an act of corruption on its own, on the part of the governors and the government. But how many media challenged the governors? Women who were most in dire need of COVID-19 interventions did not benefit because these were carted away. They were looted and kept somewhere. And women dipped deeper into poverty baseline. So when we talk of feminization of corruption, this is it. The media did not demand for answers. I mean, what about discrimination in workplaces against women? So, you know, we continue to implement our mandate to women with the support of donor agencies like MacArthur Foundation, UN Women, RAPA, Action Aid, partnership with HACI. You know, we have been able to consistently demand for accountability and show how corruption affects women through our programs and events. The media owe a duty in shaping a safe community through continued programs, reporting on to fight against GBV. Transparency, as you know, is key to achieving accountability. Information can only become powerful when it is continually used to trigger public opinion and influence leaders. And that is what we need to use the media to do. On Women Radio, and I'm sure on a few media, print media, we do a countdown every day on the Chibok girls, on Leah Sharibu and others suffering GBV. That is the only way we can keep demanding for justice. That is the only way we can keep asking, reminding the government and leaders of their responsibility to bring back all our girls and women in captivity and boys in captivity. And I feel every media should do that. If we all use our various media platforms to amplify GBV and talk about HIV, we would collectively create a safe, secured Nigeria that we want. The woman agenda should be a national agenda, and only the media can make this a possibility by putting the woman agenda on our editorial agenda. So in conclusion, I will say, let us fund the media to enable us to respond effectively and prevent GBV as we collect evidences for our use to amplify accountability in ending GBV. The media needs to do more. The media needs to take on a more active role in ending GBV and ending stigmatization for victims or survivors of HIV. Thank you very much.
You have given us a lot, myself especially, a lot to think about, about GBV. And this is a much needed reprimand, I think, for the media at this time. And I really appreciate that it's coming from a fellow woman and not the men who sometimes don't understand exactly what the issues are. Thank you very much, Tom, for drawing up these issues, especially. I mean, really, you don't need a soothsayer to tell you that the media really has failed. We hardly put the spotlight on GBV, on gender-based violence. And as you said, with the palliatives, we really didn't call any attention to the impact that this has had on women. And the Joy Nunez story, a perfect example, of us not really attacking the issues. And we tend to lean back and, be overwhelmed by all the other issues that are going on in the country. The COVID-19, we focus on corruption, we focus more on what the government is doing, than on the impact of what the government is doing on the people. Great insights. Thank you once again for speaking to us. Appreciate this, really, really do. Thank you so much, Tom.
Thank you.
So next we have Dr. Amaka Harno. She is a public health professional with experience working across multilateral organizations and government agencies. She's also experienced in the design, implementation. Okay. Sorry. Just lost where my notes were for a minute. Sorry, before I go on, just a reminder here that if you do have questions, you can send in your questions to the public chat. I will be responding to these questions. So if there are any issues that have been raised that you feel need to be further addressed or you need more enlightenment on, it will be a perfect time to actually send it before this webinar is over. So back to Dr. Amaka Haruna, Moma Haruna, I believe. She's a public health professional with experience working across multilateral organizations and government agencies. She's also experienced in design, implementation, and evaluation of large-scale public health programs with a core expertise in early childhood development, and has had 8 years of work experience with health projects in sub-Saharan Africa. She'll be speaking on accelerating progress to end gender-based violence and HIV for young people, the challenges and the opportunities. Dr. Amaka. Okay, here she is.
Okay, yes. Hello, can you hear me?
Yes, I can. Good morning.
Hi, good morning, everyone. Yes, thank you so much for the introduction, Amarachi. I think a lot has been said already, especially by my boss, Dr. Gwamna, as regards, but I'll speak specifically for you to young, or as regards young people. So I work with the United Nations Fund, United Nations Population Fund. That's we're the lead agency for the sexual reproductive health and rights globally, the lead UN agency in promoting sexual reproductive health and rights. And when you say sexual reproductive health and rights, it really covers the two topics we're talking about, the gender-based violence and HIV, quite concisely. For us, we are also the mandate agency for young people. And in Nigeria, we do a lot with the government in ensuring that young people's rights are protected and understood and promoted accordingly. I will stick to what I was, the brief I was giving around challenges and opportunities. I'll speak specifically to gender-based violence first. For young people, I would say a lot around what the executive officer for We Radio has said. It's quite true, but it's even more so for young people because, I mean, it's one thing for a woman to report her husband is she's being assaulted, you know, but for a younger girl, you can imagine it's never really, it can never be her fault. It can never be the perpetrator's fault. It's always, what did she wear? Where was she? What was she doing? You know. So the narrative around gender-based violence, especially for young people in Nigeria, really has a long way to go because of our cultural context, you know, the norms and values we hold dear, you know. And during the pandemic, when a lot of young girls were unfortunately lost their lives due to perpetrators having access to them by virtue of the pandemic, it now really brought to the forefront a lot of the challenges we have. And I mean, unfortunately, those things have been there for years. But in a way, I think we're happy that there was a window to bring it more to the forefront. Specifically, we would say that some of the challenges in Nigeria are around, first of all, regulation. The Violence Against People Provision Act in Nigeria was just enacted a few years ago, you know, after many years. Well, how does that relate to the young person who does not even know that it's a VAP Act, you know, in the first place? So awareness around it is very low. Awareness around the fact that young people don't know their rights when it comes to being assaulted. And I would not say just girls, young men as well, you know, their rights around even gender-based violence assaults, it's not known. Then secondly, when we do get these cases, prosecution is very poor. The legal process in terms of following through and getting the prosecutors getting the law they deserve is often a very lengthy process that, first of all, no young person can afford, and the parents most times don't want the public humiliation of the whole thing. So those are some of the challenges. Lastly, when I'll be speaking more around young girls, but really we need sexual assault resource centers in Nigeria. Those are places where when you are assaulted, you can immediately go to, you can really be attended to, you know. I don't know if anyone on this call can mention on the top of their head a sexual and assault resource center in Nigeria. You know, we have Mirabel, that's probably the most popular, you know, but for the fact that we don't know, then you can imagine the average young person that gets raped on a Friday night does not know where to go. Our health centers have a long way to go in being able to respond to, first of all, sexual assault and then a young person. Unfortunately, in our work, we see a lot of I'm a doctor, so I wouldn't say I'm shaming my colleagues, but the healthcare workers' response most times when you come in and say, this is, what were you doing there? And also, it discourages people from even accessing healthcare centers. With HIV, I mean, a lot of the challenges over the years have been overcome, but there's still a lot of things. Testing for young people is still not as easy as it can be in terms of accessing it. They have a lot of challenges and difficulties around that. Then even when you have been diagnosed as positive, accessing the services, I have a lot of young people that are positive that I work with that have to go to school all over Nigeria. And every 3 months have to make that journey back to their base every 2 or 3 months to access their medication and then go back. A lot of them don't have the money to do that. You know, a lot of them, why would you need to travel maybe across 2 states to go back? Because the way our system works in Nigeria now is as a person living with HIV, wherever you began your treatment, you know, we don't have a very efficient system that transfers you to, as you are moving, if you have to move, you know, where you go to next, they transfer you, then you take your drugs. So these young people who were positive all their lives, by the time they become teenagers and they go over to universities and schools, maybe you were born in Lagos, but you got admission in Calabar, you have to be coming back for the 4 years in your university. You have to come back every 2 months to access your drugs. You know, young people cannot afford that. You know, so those are some of the challenges around that. And also, Dr. Gwabna is my boss, but you know, it's really interesting for us to see, you know, in terms of some of the things that young people living with HIV want to have answers to is, you know, where are we going to? Because now there's a little bit of introduction for fee for service. For someone who is working, as a person living with HIV, if you are working, you know, you can put that in your budget, you can, you know, your tests, your monthly tests and all those things. But a young person, how are they going to be able to be tested so that their health can be maintained? You know, so those are some of the real challenges we have with young people living with HIV, or even those who are not living with HIV but want to access treatments. But it's not all doom and gloom. There are some opportunities. We're going to be more positive since it's the end of the year. You know, we all need some good news. You know, as I said, the awareness around gender-based violence now is really awesome. It really has come a long way. UNFP and other UN agencies. There's an EU UN Spotlight Initiative. That's a 500 million euro initiative specifically for gender-based violence in Nigeria. UNFP is one of the lead agencies working, you know, and there's this complete portfolio for young people in terms of increasing digital access to preventing gender-based violence. In Lagos State specifically, I'll call out Lagos, they are my big constituency because I cover the Southwest. You know, Lagos State now has a virtual GBV referral service where, and that's really by the lead of the government. We give the full credence to Lagos State government. They have a domestic violence and sexual response team that has been very, very active. So now, you know, in Lagos State, you have numbers you can call in that actually call you back, that follow you to your home. And if you need to be protected, kept in a place where that you are protected from the perpetrator, you get that service as well. So those are some of the things, and they're working a lot with schools, so young people have access to those things. So those are some of the good opportunities that are coming up. Then secondly, as regards HIV testing, self-testing is really going to change the needle when it comes to HIV testing for young people in Nigeria. We're very glad that the government is leading on it, you know, because once a young person can access the test, walk into a pharmacy and get the test on their own, it cuts out the bottleneck of stigma or a healthcare worker being not very receptive, you know, all the other challenges people have, even costs in getting a HIV test. So those are some of the things we have coming. We also have very active NGOs in this space. I definitely want to mention HACI. HACI is definitely one of the many NGOs in this space really speaking to increasing HIV prevention and treatment for young people. It wasn't like this a few years ago. I mean, just the space has increased a lot, and that's going to make a big difference in HIV programming for young people in the long term. Lastly, we also have a very strong network of adolescents living with HIV. And I think it's very important as Nigerians that we focus on the future. Just before I go, something I'm really passionate about going forward is the fact that Dr. Gwamna he's our Oga, you know, in the HIV field. But when they got started, all those people that were HIV positive, you know, they got infected probably through, you know, needles or sexual intercourse or different ways. You know, it was not, it wasn't by birth. That was about 20 years ago. Now those people have gotten married, you know, when the epidemic wasn't as manageable as it is now, you know, and they had children. We have a significant proportion of young people living with HIV that were born positive, that are were born into the world knowing that they're HIV positive and really not knowing what to do. So that's a big program gap we have in Nigeria. You know, you have, I don't want to call figures, but in Lagos alone, you have about 50,000, you know, of young people living with HIV who, first of all, and I need to go because I could talk about this forever, you know, first of all, they did not know they were positive till most of them were in their 20s, you know, and by then they'd already been sexually active for years, you know. So you are positive, you don't know you are infecting other people, you know, and we don't have the structures in place to support them. So we have a lot of young people now who are living with HIV, you know, but are not able to protect their partners because a lot of them are in heterosexual relationships with people who are not positive, you know. So, but we don't have structures in place to even support those kinds of things. So those are some of the things, and even they themselves, making sure that as you are a positive young person with HIV, making sure that your child, the child you're going to give birth to in the next few years is not positive, because a lot of our programs don't focus on those people who were born with HIV. We just focus on the adults and all those things. So those are some of that for me, I think was my key takeaway for this World AIDS Day. You know, that please, as a populace, as Nigeria, we need to focus on young people who were born positive, who are living their lives positive, who have issues around getting jobs, because sometimes some jobs have to screen you. It's a whole different kettle of fish, but I will happy to take any questions, and thank you so much for the opportunity, and look forward to other discussions. Thank you.
Dr. Amaka, thank you. Thank you for drawing attention to young people living with HIV/AIDS and staggering figures. I know you're trying very hard to hide some of the figures, you know, that you have there concerning the numbers for 50,000 in Lagos alone. And I'm sure it is much more than 50,000. These are just reported cases, because there's always a larger community of people who don't talk about it, or who have never come forward to say, oh, this is what I think I might have, or I've done a test, what do I do now? Where do I go? So really important, you know, that you're bringing out these significant figures and you know, thought-provoking issues, especially for young people, and the huge gap, you know, of those who were born with HIV/AIDS and not knowing that they actually do have and are living with HIV/AIDS. Dr. Amaka, thank you again. Once again, if you have questions, please put them in the Q&A right at the bottom of your screen. It's available. We'll be taking questions at the end of this webinar. So all of the speakers will be available to answer your questions, as many as you have, and as profound and as deeply as you want them to be addressed. Thank you so much. So we are going on to Mr. Isaiah Owolabi. He is, I would call him the Oga Patapata of HACI Initiative, because that's what he is. He is the co-founder, actually, and project director of HACI the Health Initiative, a development organization, if we didn't know before. And I know that many of us know HACI. We've had interactions with them over the years, either by association or by profession or otherwise. The HACI is a development organization that leverages multi-sectoral and intergenerational innovations to improve the health and economic outcomes of underserved women, beg your pardon, and girls. HACI began in 2007. It's expanded to 13 states in Nigeria, and with more right ahead in the coming years. It's reached over 300,000 people. I know it may seem like a small organization, but it's really been doing a lot. and they have been doing it pretty quietly too. They reached over 300,000 people through capacity building, advocacy, research, and education. Mr. Owolabi will be speaking on innovations for impact, rethinking new models for HIV and GBV programs. So I'm really looking forward to this one. Mr. Owolabi, you have the internet.
Hello, everyone. Thank you, Amarachi. Can you hear me?
Oh, yes, I can, and I'm sure everybody else can too.
Okay.
We just have our mics muted.
Okay, that's fine. I was speaking on innovations for impact, rethinking new models for HIV and GBV programs. We all know that effective public health interventions depend on timely, accurate surveillance, and we also know that harnessing digital data, including internet searches, social media and online media and data science, is an emerging approach to complement traditional surveillance in public health, but has been underutilized in HIV prevention and treatment over the years. When we talk about innovation and technology, we know that this is very much relevant for all development space, not just the health space. But very much important is the fact that we should learn how to leverage on innovation and technology to accelerate the impact of HIV and gender-based violence intervention. And some of the biggest lessons that we could have is first, understanding how technology and innovation works. The essence of technology and innovation is not to exclude the beneficiaries from the project. So whenever we design a technology or we come up with an innovation that exclude a huge percentage of the beneficiary from a project, then that's not a relevant technology. So when we are talking about leveraging on technology or rethinking new models for HIV intervention, we are discussing about how we can leverage on useful and relevant technology to make sure that we are not only reaching more people, but we are also able to coordinate sustainable efforts, which includes even training HIV and AIDS workers, monitoring and evaluation, and also making sure that we are effectively coordinating and making best use of data. Dr. Amaka spoke earlier about the fact that for many young people, some of their biggest challenges in accessing HIV services or treatment is the fact that many of them have to travel long distances. And in many cases, some of them do not have the finance to cater for this. With technology, we can bridge that gap. And we can use technology to connect most or all HIV service providers across Nigeria to make sure that they are not only making prompt service, but they are also providing accurate service because technology can help to improve the electronic health records and also ensure that wherever and whenever anybody wants to access HIV information and services, they can access it once they are able to reach out to a health or to a service provider. These are some of the things that we can leverage on technology to achieve. We strongly believe that to achieve the 1990 goals, which was earlier discussed by Dr. Jerry Gwama, to end HIV epidemic, we encourage traditional public health researchers to partner with data scientists to supplement HIV surveillance programs with social media analytics to refine estimates of HIV infections and key populations at risk, and to identify subgroups and regions where prevention and treatment efforts need to be bolstered. We also encourage interdisciplinary teams to design intervention to promote HIV prevention and linkage to care by leveraging on digital media such as search engine and social media that have the potential to reach millions of people instantaneously. Now that's very important. It's almost impossible to define this generation without talking about social media. many would refer to this generation as being digital natives, not digital migrants. Many people who were the first to experience HIV and AIDS. I mean, many people who were the first to be infected by HIV and AIDS, they lived in a generation where they were probably digital migrants, which meant that they were not natives to digital technology. But the generation of people we have today, I mean, the young people that we have today, um, they are digital natives, and we cannot ignore that fact in designing HIV programs. If we look at the most recent NICE report from the NACA, that's the Nigeria AIDS Indicator Survey, we would see that the incidence of HIV/AIDS among young people is increasing, despite the fact that overall the report shows that Nigeria is doing well in terms of incidence of HIV and AIDS. But we can see that within the age group of 18 to 24 or even 18 to 35, the incidence of HIV is not quite reducing as much as the investment made into HIV programs. But how can we start thinking about new models to create effective and long-term solutions to HIV and AIDS program? First, we need to explore ways in which technology experts and data scientists need to work effectively well with health workers and program planners in Ministry of Health, civil society organization, and even across social enterprise and technology-focused organizations. We also need to expand the definition of private sector when we are within the health context. Many times when we talk about private sector, we're referring to PPMVs, which are the PMX vendors or even the pharmaceutical companies. But there are bigger opportunities in the larger private sector, which include technology companies like the big tech companies or big data companies. They can leverage on their expertise, for example, to improve surveillance program. They can leverage on their expertise to improve, for example, health promotion programs on HIV and AIDS. The way private sector organization has leveraged on analytics, big data analytics, to inform marketing approach, to go beyond just describing demography, but to also be able to analyze psychographic factors and other elements that helps them to target their marketing information to exactly the people online. And you typically notice that the next set of adverts, up to 20 adverts, that you start seeing will be related to what you have searched for online. For example, you just search for how to buy a house in Lagos. You notice that the next advert you start seeing across your social media platform is properties. That way, we can also leverage on social media platforms and social listening tools to make sure that health promotion programs are not only directed to people who already get this message, but directed to people who need the message most. Young people who are leveraging on different tools that social media has to offer. We also, beyond social media, have to leverage on innovative ways or innovative technological tools such as machine learning to be able to also predict how some of the incidents of HIV and AIDS might happen, or to be able to provide detailed insights on HIV and AIDS transmission that can even help us to address issues related to mother to child transmission and transmission among the youth population. It's important to note that linkage and retention in HIV medical care remains a problematic issue in Nigeria, not just in Nigeria alone, sub-Saharan Africa. And extensive health utilization data collection through electronic health records and claims data represent new opportunities for scientific discovery. Big data science is a powerful tool for investigating HIV care utilization patterns. And in conclusion, I would highlight some of the things that ACE is currently doing by leveraging on digital technology, for example, to map all youth-friendly sexual and reproductive health centers across Nigeria through our tombe.org platform, TOMBEY platform. We've also leveraged on our Code for Impact program to work with young girls, especially to create technological solutions that address HIV prevention and treatment challenges across Nigeria. Lastly, I would say that at AC, we strongly believe that data could make the difference. Vast volumes of structured and unstructured data are collected on the millions of people living with HIV and AIDS in sub-Saharan Africa and even globally. But sufficient insight isn't being gained from it. This could be improved through more widespread use of advanced analytics techniques such as clustering to better understand at-risk population, predictive modeling to understand likelihood of risk for an individual, and optimization of ART inventory. The insight garnered using these techniques can be used to predict patterns of disease, optimize treatment decisions, and improve patient experience, to name a few examples. I want to say a big thank you to everyone that has spoken and to everyone joining us today. Thank you very much for having me.
Isaiah Wolabi, thank you so much for speaking to us, especially on the social innovations that are being formulated to help young people, especially to talk about HIV/AIDS and also to stay safe. I know that with seminars like this, especially when you're going on the web, I see most people's cameras are off, so I take it that people are doing other things. I know it's a busy day. This is a webinar holding during the week, but if we could just turn on our cameras for just a bit, just so that we know that we're participating. If you could just turn on your cameras. Okay, so if you're with me, do raise your hands. I've been told it's really good exercise. Raise your hands, raise them as high as you can, bring them down, because webinars can be boring too sometimes, can't they? You know, when you're listening and you're being loaded with lots of information, it's very easy to get lost in the sea of information that's, you know, coming to you. So just raise your hands again, reach them out to the sky, shake them, shake them, shake them, shake them. I know many of us have probably done breakfast, but for some of us, breakfast is not our thing. So we have to do what we can to stay awake. And if there's nobody around you, might as well just clap your hands and just clap for yourself, because it's not easy to sit for 1 whole hour, you know, or an hour plus to listen to some very important people. So you deserve the round of applause for yourselves. Thank you, everyone who has spoken. Thank you so much. I really, really appreciate your patience. It's busy, and my media colleague Tom is also probably also busy. I know what it's like being in the office and doing Zoom calls and having Zoom meetings. You want to be doing other things while you're also listening to what's going on. So, and thankfully, women know how to multitask. So, I'll just leave that there. Our final speaker. Well, that is true. Our final speaker today, she's the last but not the least, and probably one of the most important people we have today, because she's a young person. She's Jola Ayeye. She's the head of development at Salt and Truth. It's a story-driven production company with a chosen mandate to create rich, authentic Nigerian stories for a global audience. Jola is a writer. She's a storyteller with a core interest in contemporary African culture and its presentation on the global stage. She hosts 2 podcasts, which unfortunately I've not been able to listen to, but I will after now. I Said What I Said, and I'm hoping that she will give us some insight into what she said. A pop culture podcast, and Cash Madam Collective, a podcast focused on the world, work, money. You know, she's a writer And oh, my internet is unstable a bit. Okay, we're back. I'm excited because she's a writer and also because she has, you know, an outlet to express her views, especially from the point of being a woman. Jola, you have the internet. Tell us what you've got. She will be speaking on, Jola will be speaking on achieving an HIV-aware and GBV-free generation, the role of new digital media. That's something linked to what Isaiah was talking about just a few moments ago. Jola, you have the internet.
Good morning, everyone. Thank you so much for having me. It's been a really informative and interesting webinar so far. I'm going to make mine quite brief. I think quite a number of people have touched on the importance of the media, and Dr. Isaiah also mentioned the importance of new and digital media. Now, just a few quick stats. Nigeria is very difficult. I mean, most of us here have had to work with gathering data and information, and we all know that in Nigeria, it's quite difficult actually to gather and get information, and some of it might be outdated, so please bear with me. But there are apparently 169.2 million mobile connections in Nigeria. Now, I am aware that a number of people do have, you know, multiple phone lines and their business lines as well. But that's a huge number of people with some sort of mobile connection. At the last count, there are 27.1 million Facebook users, 6.4 million Instagram users, and just over, no one is really sure about the number on Twitter because they're not very forthcoming with their users, but, you know, from people's estimations, it seems they're about 7 odd million Nigerian users on Twitter. According to a paper on GBV and COVID-19 written by UN Women Programmer and analyst Jessica Young and Cameron Arif Aden, 30% of women and girls between the ages of 15 and 49 have experienced sexual abuse in Nigeria. That's a huge number. And there are over 3 million people in Nigeria living with HIV. In what is supposed to be over the, and I think about 90% of those are between the ages of that same age bracket. So in what's supposed to be a really, really vibrant and productive and exciting time in their lives. The main thing I'm going to be talking about is how we can continue conversations and maintain awareness of HIV and create the possibility of a gender-based violence-free generation using new and digital media, what exactly the role is. The first thing I would like to mention is that over the last couple of years, it's really, really been interesting for me to note how, even though new and digital media only continues to grow, it is constantly discussed as almost like a minor when people are making sort of plans on strategy and communication, even though more and more people are actually using digital and new media. Think of how much information you're loaded with using your WhatsApp. I mean, my parents are obsessed with, you know, all the things they tell me about is, I'm like, oh, where did you get that information from? Like, oh, we saw it on WhatsApp. Oh, we saw it on WhatsApp. We saw it on Facebook. There's just, and for some reason, there's a high level of trust in this information. There are downsides to that, but it seems that more and more people are getting information from digital and social media. And for some reason, because the information is normally shared from a contact or detail that they trust, they tend to trust this information. And so I find it very interesting that within corporates and NGOs and the development community, when people speak of digital and social media, it's still often as, you know, an aside or a footnote, as opposed to having your plans and your strategy with digital media as part of your main focus in communication. I do agree that in Nigeria, terrestrial forms of media are still king. So, you know, there's radio and there's television, and those things are still very, very important. But with increased mobile penetration, with data getting cheaper, with mobile access getting cheaper, fancy digital phones are getting cheaper. You know, it's no longer, you don't have to have a very expensive luxury phone to have access to the internet. Those phones are getting cheaper because technology, the creation of technology is so commonplace now that people are trying to basically just reduce costs of people having certain types of gadgets. And so more and more people have access. So how do you use new and social media to get this sort of information out? It's really important that you meet people where they're at. And what do I mean by that? There's a lot of social media apps and social media and digital media. It's not just Facebook and Instagram and Twitter. There's Clubhouse, there's TikTok, there's Musical.ly, there's a range of digital and social media. If you're Nigerian, there's Nairaland. These are huge, huge platforms that millions of people gather every day. And it's important in the same way in traditional advertising, people say, this is who we're targeting with this messaging. You need to figure out where your audience is and how you're going to communicate with them using that audience. TikTok is full of Gen Zs. They are vibrant, they are smart, they love to use music, they're very witty and very irreverent. You will not use the same messaging where you have slightly more traditional social media users like Facebook on TikTok. It won't work because those audiences are quite different. Twitter also limits the way in which you speak. You can't have lengthy essays or full slideshows or videos. You're more likely to lose people. You need sharp, witty, fast 280 characters information that kind of pack in what you're trying to say as quickly as possible. Who is also on Twitter? You find people who are quite opinionated. They often love to laugh. They can be quite combative at times, but you need to make sure that your information is being geared towards those types of people. Who is on Instagram? Instagram is a place where people go to get a lot of information, and more often than not now, based on new changes, are now going to shop. They want bright and vibrant pictures. They want interesting videos. So you're not going to have heavy, wordy content or, sort of like witty talk like you have on Twitter or a Facebook or a TikTok on Instagram. So it's really, really important that when you're trying to decide the role of, your digital strategy, you have to be very, very specific on what medium you are talking about. It's very, very rare for the same messaging to scale across different social media platforms. It's really important when you say you want to create conversation that you realize that the world is really, really changing. I'm sure everybody here already knows that, but the ways in which the world has changed very often kind of surprise people, if I may say so myself. In the last 2.5 weeks, I've had so many interesting conversations that I don't think I would have in my regular everyday life on social media. So let me give you an example. A few days ago, a friend of mine hosted a room on Clubhouse where she spoke about the difficulties in miscarriage and having a baby right after. What does that feel like? What does that look like? What sort of resources are available to you? And there were over 100 women who had nothing in common but an interest in the topic. They really didn't necessarily know each other beforehand. They lived in different countries and in different states. And the conversation was absolutely interesting. I'm not a mother, I've never been pregnant, but it was very interesting to be able to sit in the room and hear what these different women experience all around the world. I've been in conversation on social media surrounding women's access to family planning, options when you're pregnant, options to keep yourself safe, options to safe sex. These are all conversations people have very, very casually on social media. And I think it's really, really important that those at the forefront of development of these issues are figuring out ways to craft messaging and partner with influencers and savvy social media users on disseminating messaging. A friend of mine joked with me a few months ago that she never really knew how many options she had in terms of her sexual health until she got on Twitter. And it was never said in a lecturing way. It was always like, oh, by the way, did you guys know about these types of condoms? Have you ever heard of this type of birth control? Apparently, if you go to these sorts of clinics, this is how much it costs to get an appointment with a doctor. And this is information that a lot of us in this room have been struggling to get out for years. It seems like, there's just constant barriers to getting this information out. But new media is honestly at the moment like the wild, wild west. in the US Senate, tech, we call them tech bros, but the founders of these huge tech companies are constantly having to go into Senate to kind of explain what exactly it is they're doing and how their business works, because it's still, even though it's been around for over a decade, it's still very, new and difficult to kind of understand how exactly it works for people who are used to traditional media. So there's so many avenues for the development space and health space to exploit in getting your information out to people. It's like I said, when you partner with influencers and new media content creators, please listen to the people you're working with. It can be difficult because we have a set way of doing things. And so when they start talking to you about how their audience receives information, it's not necessarily something that may sit easy with people who are used to doing things a certain way. But please be open to collaboration and passing across your information in a certain way. Remember that what's important is young people have a space to express themselves, to ask questions, and to receive information. That parents are also being carried along on this journey, that people who have grown up in very strict or restrictive environments have a way that they can gather information. The role of new and digital media is not always spontaneous and kind of hoping to trend. There's also deliberation. Ads are really, really important. But like I always say, it's not just about having ads, it's what's in the ad and where is the ad going. Shining a light on stifling gender norms and the ways in which they continuously form a barrier to providing information and changing minds. We are all working in a terrain that is deeply patriarchal, that is very, very high on respect and can be quite, what's the word? We can be very shy or have a stiff upper lip about having certain conversations. But there is a way in which very many people within the development space have found ways around it. One of my favorite shows ever, as a writer myself, is MTV Sugar. MTV Sugar was done with Bill and Melinda Gates Foundation to kind of create content that just talks to young Africans about their sexual health, about AIDS, sexual reproductive health, gender-based violence. It was interesting, it was touching, it was funny, but most importantly, it passed the message. And I think it's really important that we begin to think of things like this as the norm and not a one-off if you're trying to connect with a wider audience. Not everyone is going to read the paper, even though you worked really, really hard on it, and we know it took a number of years. Not very many people are going to sit down and read a paper with big numbers and interesting terms that they've never heard of before about HIV or GBV. It's really important that we think of the fact that people have shorter attention spans. There's a lot of things vying for information and attention. And even though there's not a single person you're going to speak to who's going to say, oh, I don't care about information on HIV. Oh, I don't care about gender-based violence. Everyone knows that these are really important topics, but you're in a world vying for every second of individuals' attention. And using new and digital media means that we all have to be very, very creative in how we go about passing and disseminating information. Another important thing I've realized that new and digital media does is it creates cocoons. So very often what happens is that within social media, people find ways to create safe spaces, no matter how small, allowing people to have very, very important or difficult conversations. I think a very interesting example is Female in Nigeria on Facebook. That's a huge, she has I think over 1 million women are in that group. And every day they share very, very touching, difficult stories around this exact topic, around this exact subject matter, and somehow are constantly able to connect with each other, get information and advice, find help. And Facebook is notoriously open and it's easy to find people and find information, but there are pockets of safe spaces, and it's important that the development space finds ways to partner with people who have created these safe spaces to disseminate information. Last year, I filmed an ad for a friend of mine. It was a small digital ad, but it was about, she created these birthing kits in rural areas, and she was trying to get people to sponsor women in rural areas with these birthing kits. And so we went to film in a really small clinic in Obalende, and I got to talking to some of the doctors. And I didn't realize how much was available and for really, really little prices. And when I asked the doctor, how come this information isn't public? She was confused. She said, but everybody knows this information. I was like, no, I live down the road from you and I had no idea. So I think it's really important that HIV and GBV champions or advocates are constantly making sure that information gets to the people, that it's not just to have the information or create the information, it's understanding that new and digital media is powerful in that it gets to people right where they are. So they don't have to get to a television or buy a newspaper to get the information. They don't have to download a paper from the internet. You can be right in their faces, you can be right in their homes without jumping through as many hurdles. Once again, I do think that lots of people are doing an amazing job, and the role of new and digital media is not very different from traditional media, in that everyone who is a user has a responsibility to make sure that the information they are sharing is correct, that there is no judgment when we're passing across this information. But the onus is on those of us who care about this information, who understand the value of this information, to work extra hard and keep new and digital media, not just as an aside, but at the forefront of any sort of strategy or planning in deciding how we are going to disseminate information. It will also be important to understand the terrain in which we are working. Digital and social media in Nigeria doesn't exactly have the full backing or weight of the government because they don't really necessarily understand it. So when we're making these decisions, that's something that we do have to keep in mind. I'm not going to go on much further than this. I think I've said enough points, and thank you once again so much for having me. I've been having a wonderful time. And if anyone has any questions, please do feel free to put them in the Q&A box. Thank you and have a great rest of the session.
Thank you. Thank you so much. Interestingly, you are our final speaker today. I like the way you compared new and digital media with traditional media. New and digital media is not there to replace traditional media. It's only there really to complement it. And that's because the younger this generation gets, the shorter the attention span that they have. But the most important thing is getting the correct information out there. Thank you again, Jola, and thank you for all the work that you do with your podcast and of course with your writing. I hope to have you on one of my shows one of these days, if you have the time.
Of course, just let me know.
Great. Okay, so very quickly, because this was supposed to end at 12, there have been some questions that have come in. Some of them I see have already been answered by Hasty Health Initiative. Some, yeah, we have, okay, some have already been responded to. I'm not sure if we're going to take, but I think that some of them we should take a few of them and have, you know, the speakers respond live to some of the questions. I think someone was asking something about, let me go to the question itself, because someone was asking, well, I think this was already answered though. Is it safe to be in a relationship with people born with or those living with HIV/AIDS? I believe this question is directed at Dr. Amaka Haruno. And she might as well answer this one too. What can a GBV advocate do when a child is raped, refuses to be taken to the hospital for medical reports for fear of stigmatization? She did give the person who sent this in, Blessing Ekpo, gave an example, a young girl being raped last week in Cross River State, and she was called upon, but on reaching there, she says the girl refused to be taken to hospital. Dr. Haruno, if you're still on the okay, so I take it, Dr. Haruna is not available. Is she? She's not.
Yeah, I think Dr. Jerry Guama can take it.
Okay, okay,
so,
Dr. Jerry, please go ahead.
Yes, so, all right. So the first question is something I think I can address. Basically, there are ways to be safe and be in a relationship with those who are living with HIV, whether whichever way they acquired it. So there are safer sexual practices we train for people who live with HIV. That's one. Two, we teach them rather what they can do as long as that relationship is open, in terms of knowing the status of one another between them, and so they can do things to help one another and still have a good life. The other one is also the fact that basically we have treatment, and the treatment actually can make them get to what we call viral suppression. So when the viral load level is below 1,000, or in some instances over 200 copies per mil, and at that stage, they are not able to transmit sexually. So that is good. So if they sustain that treatment, there's no problem at all. You have no fear of getting infected. But even at that, we still advise the use of condoms and other things unless you are ready to have a baby, and those ones the doctors will actually advise you what to do and how you can have that period when you cannot you will not use condom for the party that is supposed to be pregnant to get pregnant. So all of those are there. So secondly, there was a question also that talks about whether you can live for 20 years with HIV in these days. I mean, you can live for life, your entire length of life. In fact, you'll be normal, you won't feel sick as long as you're on treatment. And the focus is, many times people think that treatment is not prevention. So we can't have one without the other. We can't be talking of prevention without treatment. Actually, treatment is the best form of prevention, because if we can get all those who are infected and place them on treatment and we achieve viral suppression, then we actually practically eliminate sexual transmission, and we'll only be worried about, if they transfuse blood to somebody or other things like that that you have to worry about. But generally speaking, getting that right treatment is very important. As long as that person is on treatment and they're achieving viral suppression, your risk of contracting HIV is basically non-existent. That is actually what drove the 1990 that we're talking of, the UNAIDS 1990, or for us in PEPFAR 95, because if we get the majority on treatment and they achieve viral suppression, then basically transmission is reduced to non-existent, and then we may even have AIDS-free generations coming, people who will never even know of HIV/AIDS. The other question is a bit tricky, because when the child who is, the young person who's been raped refuses to go see a doctor, it requires a lot of counseling and psychosocial support. That's what that is calling for. There are experts who will be able to do that for them and help them break through that barrier. And they need the assurance that wherever they are going for services will be sensitive and not stigmatizing. It will allow for audiovisual privacy, that whatever they are discussing will not go anywhere. They will receive non-judgmental attitude in terms of the services that will come in. They will be provided to them. I think those are the reasons. But it requires that kind of counseling for them to reach to that level that they are open to actually accepting the services. But then this has to be done urgently, because the earlier the better, especially with the risk of getting, contracting HIV from such rape. If you don't get there on time, like we were talking of, within 120 hours, you may not get the post-exposure prophylaxis that are supposed to help prevent you from getting HIV if you stood a risk in case the rapist was infected and has deposited HIV in you. So those are the critical things that I would should talk about. If I may, I have one or two things that have been discussed on the platform that I want to just address quickly, if you don't mind. One of them is about the facts about our epidemic in the country. When we are saying we have about 3 million people infected, that's old news. That was based on the repeated ANC Sentinel surveys we used to have, which actually basically took HIV prevalence amongst pregnant women, HIV positive women. That was really not a very good representation of the entire population, but that was all we had. So we had to be using that. That gave us an estimate of about 3.2 million people as at the last prevalence of, I think, 3.0 for Nigeria. Before then, we did the National AIDS Impact and Indicators Survey that Isaiah mentioned earlier, which actually recalibrated our prevalence to about 1.3, 1.4% as a country. And using that with the EPP spectrum estimates, that means we use some population estimates that the United Nations uses to juxtapose with that prevalence. It gave us actually that the estimated number of people living with HIV in Nigeria is now 1.9 million people. So which means it's far less than we thought. So it's critical that we get that corrected, because that's a new base from which we are now calibrating how many we need to find and how many we need to place on treatment in order to achieve the 90-90-90. So I want that to go well. Dr. Amaka Haruna, she really put me on that. She said a lot of things that I think it would be good for us to also clarify and help us understand that things are moving forward. The user fees, we are working hard at actually removing user fees. We've worked with certain governors, they've actually eliminated user fees for all people living with HIV, particularly Rivers and others like that. So this is something we are working hard on. And then the issues of young persons having challenges when they move like across from one state where they were living to another place in school, they have to go back to where they were to get services. That has also been eliminated by the use of NDR, which is the National Data Repository that the National Ministry of Federal Ministry of Health is controlling, and also the fact that we allow our partners. I think COVID-19 gave us a lot of lessons. Our partners are now able to identify and give the person their card. Wherever you go, you can just show that card and say, if you are providing HIV services here, I'm PL-HIV and I need my medication, and it will help them. They will trace you back to your referral facility and give you the services you need. So you don't have to be where you used to be to get your medications. So all of those are being, improved now in the system. So it's helping our country move better. Then for the younger persons that are, we have born with HIV from their parents directly and actually got to know it. Yes, there was a big issue about status disclosure. Parents were struggling. How do we tell this child that they have HIV, and how do we explain how they got it? And it actually tallied. So many parents couldn't tell. But now we have a program they call the OTZ, Operation 000, which is actually youth focused and is targeted at young people living with HIV. So we have them like clubs across the country in different states where we're doing the programming, and facilities actually run those. So they provide safe space for young people living with HIV to discuss issues and to address their real significant challenges they are facing. The Operation 000 helps them to focus on achieving no missed appointment, also making sure there is total adherence, in other words, 0 missed dose, and then also making sure that they are actually continually on treatment, adherent all the way at the end. So that's very important that they know that they are now achieving what we call viral suppression. Again, we couple that with the U=U campaign, which actually drives them to believe that once I'm reaching, viral suppression, I do not transmit, so I'm no longer at risk. I can have a love life and enjoy my life and live long too, like everybody else, a productive life, and be, life expectancy of Nigeria is said to be 52, but I can even live 60, 100, whatever, it doesn't matter. So as long as these things are ongoing, we are actually helping these young people do better. So this is what we are using to help break those chains for them in the past that has been there. We also are using a lot of technology now compared to before, because in patient-centered approaches, you must reach people where they are and the way they want to be reached. And COVID-19 again was the greatest innovation for us. Even though it was a challenge for everybody, it made us think differently in the way we deliver services. A lot of people were reached through technology, WhatsApp groups where we pass information and they actually make suggestions. If we're in Lagos, around this area, where can we get our ARV? And the partner staff or facility staff writes, oh yeah, we will come to your place at this location, this particular hotspot or whatever. We will supply your medications there regularly on so days, so you can be coming to collect there instead of coming to facility. So different things were happening. So a lot is happening in terms of changing the way we program in order to be more responsive to the needs of the client or patients. So this is very critical. I hope we are making progress well across board too with other implementers. I'm just sharing a bit of what we do in CDC along with our implementing partners. Thanks.
Thank you so much. And today being World AIDS Day, there are so many questions on HIV/AIDS, but someone is also asking a question on GBV survivors to emphasize on EC and PrEP. But I think that question may have been answered by some of our speakers already. You, Dr. Gwamna, Dr. Haruno, and I believe also Tom also spoke about that. Tom, if you're still on, could you please talk more about, what the media really, how the media can overcome the challenges, the concerning reporting of GBVs and so on. And Jola, if you're also on, during the lockdown, what kind of topics did you find that people were more interested in during your podcasts?
Sorry. The second podcast isn't out yet, but we took a break from the podcast during the peak of the lockdown. Excuse me. However, we realized on social media that people were just interested in a breadth of topics and social issues. People do love to debate. There was a lot of talk of what they call, gender wars, but I think that is just like a microcosm and poor communication skills and people trying to assert themselves and their worldview on how men and women ought to relate with one another. And there was a lot of talk of what constitutes as violence. Excuse me, how people sort of, what's the word, sort of progress from one stage to another, from, verbal to physical altercations and things like that. So there's a breadth of topics on social media. It honestly just takes sort of bravery and strategy to decide the way in which you want to introduce a topic and steer the conversation. But you can have almost any sort of discussion you want on social media. It's really not, you don't really need permission per se, and if you craft your narrative very carefully, you're able to carry as many people along as possible.
Thank you, Jola. I figure that some of our speakers are kind of busy with other things. So someone says, how will someone with HIV know the authenticity of the group or the authenticity of the advice he or she is taking, so as not to keep accumulating more fake instructions and complicating his or her health issues? I suppose it's also talking about social media, the information out there on social media. Jola, very quickly, on your shows, do you have like health professionals who actually, answer questions that young people may have? Because I'm seeing so many questions, rightly so, today being World AIDS Day. People are asking lots of questions about HIV/AIDS. Apparently, people still do not have enough information to stop being afraid of the virus. Someone did ask a question about why there hasn't been a drug, to either prevent HIV/AIDS or to cure it. Do you have health professionals who come on your show who also take questions? And what sort of questions are they answering?
I think a year and a half ago, we had a nurse who worked with HIV patients come on the show to kind of answer a few questions. When people send us, if we were to have a doctor, which we're talking to Hasey about, it would be dependent on the audience. So there's information that Hasey would like to get across, but then we would also have people send in questions using sort of like a Google form or tweeting at us or sending us messages. And because podcasts are sort of like online shows and they're not live, they're pre-recorded, it's pretty easy. Again, just kind of let people know, oh, this is the guest we're having. If you have any questions, please send them in. And that's kind of what will happen, because it's not a live radio show where people can call in and ask those types of questions. But it's quite straightforward. It's, if we were going to have a doctor or a health practitioner, we would also ask them some of the information that they see a gap in how people are receiving, or they just don't know. And then we would also ask the general public to send in questions.
Okay, finally, Tom, if you're there, because I really wanted to answer. So people feel that you know, the media is the police of society. Everything that happens, someone is calling the media, calling a TV station or a radio station to report either GBVs or violence, you know, in society, or robberies or stuff like that, because they believe somehow we have direct access to government, or we have direct access to these agencies. What do you do when you get reports like that concerning GBVs? Okay. So I guess most of our questions have been answered. Apparently, this webinar has gone on for long enough, but I really want to appreciate everyone who's made the time to be here. Thank you so much for dedicating 2 hours to this webinar and for making this day as important as it is, drawing attention to HIV/AIDS, drawing attention to people living with HIV/AIDS, and all of the effort that has been made. Thank you so much, Hasey, you know, for all that you keep doing. Thank you, Dr. Jerry Gwama, for all the interventions that you have been making. Dr. Haruna, if she can hear me also, thank you for educating our youth. Isaiah, thank you for those models, you know, that help young people participate in the conversations. Jola, thank you for having those conversations also. For everyone who has spoken, thank you so much for joining us this morning, and I do hope you have a very pleasant day. We'll hear the national anthem to wrap up the webinar. I am Amarachi Ubani. I don't know why I keep thinking that either you can read the name caption or, or that's, I don't know why I keep forgetting to introduce myself. I keep thinking almost everybody knows me. I apologize because there's some who don't. My name is Amarachi Ubani. I work with Channels TV. You may or may not have seen me on TV. If you haven't,
several times. I was just wondering why we had 2 Rhodas initially, so thanks.
So if you have, I'm glad that you watch and keep watching and supporting us. The media is not infallible. That's the point I want to make. The media is not infallible. We try our best, but at the end of the day, you guys keep us on our toes. You keep us accountable, especially to the people. Thank you so much. Handing over to Rhoda now to wrap us up.
Sorry,
yeah.
I have my hands off for a while now. Rhoda, I don't know if I can just chip in one sentence.
Yes, you can. Yes, you can.
I believe you should. You should.
Okay. This is something that's a question that someone asked and that is very dear to me. Talking about gender-based violence. You know, in talking about gender-based violence, especially in northern Nigeria, where it's considered a very conservative, society, and he was asking what can we do, and I think for me, and looking at the historical perspective of how we have tried to address issue of gender-based violence in the north, it is important we change our style, especially taking away this us versus them, as in those who are ready to move forward and those who are still being conservative. If we can address that us versus them, it will open up space, increase the space for mutual conversation, and reaching a point where we begin to have some incremental changes in terms of how we begin to empower women and reduce the disparities among the genders in the North and Nigeria generally, just so that we have this at the back of our mind as we live this event. Perhaps that person wants to take that further. I mean, we are open for further conversation. Thank you. Thank you very much, Rhoda, and thank you, Amarachi.
Thank you, Halidu. Thank you so much for that. I served in the North, spent 11 months, back in 2004. So I do have an idea of what you're talking about. A very important issue you raised. Thank you. Rhoda, back to you.
Okay, thank you so much to everyone. Thank you, Halidu. Thank you, Dr. Jerry. Thank you, Amarachi. You've always been there for us. And thank you, Dr. Maka. Thank you, Mrs. Tome. Thank you, Jola. Thank you to all the participants and guests that have been here today. This is just the beginning. One of the major aspects of winning the fight against this epidemic is our continued, consistent efforts towards fighting the spread and transmission of HIV and ending gender-based violence in our society. Also, please, we are still, just as an information, HACE is still running the End Rape Culture Art Exhibition. You can find the link to the exhibition on our website and our social media pages, or you can just walk into our office in Surulere. It's an open exhibition, and what we are trying to do as part of our strategies to end gender-based violence is changing the perception about rape culture, what it is, how people promote it, even in their unconscious actions and thoughts. And once we are able to change this foundation, it is easier to address the other causative results, if I may say, of this culture that we have created. So please join us for our exhibitions, come, learn, contribute to the discussions, and do not stop talking about ending HIV, stopping gender-based violence, and working with every stakeholder as part of our joint efforts. So thank you, everyone, and enjoy the rest of your day. Thank you very much.
Thank you.
Thank you. Should we wait for the national anthem? We should wait for the national.
As loyal citizens.